you so much for sitting down with us today to talk about your recent publication, Approach to the Patient from Endocrinopathy to the Diagnosis of a Histiocytic Disorder. This is a very interesting, important, and exciting article, and I'm really looking forward to talking to you more about the motivation behind it, the significant takeaways, and to help us better understand the relationship between endocrine conditions and histiocytosis. So I'd love first for the two of you to introduce yourselves. Dr. Makras, let's start with you, and then Dr. Goyal, if you wouldn't mind just sharing a little bit about your background and why you work with histiocytosis.
Thank you very much for this kind and honorable invitation. So my name is Polyzois Makras. I'm an endocrinologist and I'm working in Athens, Greece. I'm running a reference center here in Greece for adult patients with Langerhans cell histiocytosis and Erdheim-Chester disease. And sometimes we also have some patients with non-Langerhans histiocytosis, and we try to help them within the setting of our hospital. So this is mainly my background, and beside the histiocytosis, I'm also my research interest is in skeletal disorders and the calcium metabolism. So it's that's very common diseases and common situations with this histiocytosis. That's who I am.
Yeah, hi everyone. My name is Gaurav Goyal. I'm at University of Alabama in Birmingham. I am a hematologist, adult hematologist by trade. I've had a long-standing interest in all things histiocytosis. So I have a histiocytosis clinic and program. And we have a team here at UAB who takes care of patients. And we also work extensively on the education and research to advance the care of individuals who struggle with these diseases. And also, we have started a long-term study of patients with histiocytosis to understand the late effects or long-term difficulties that patients with histiocytosis experience, including things such as hormone disorders.
Wonderful. Well, thank you both so much. Really so grateful to have your expertise today and to talk more about this article and publication. So, Dr. Goyle, would you mind sharing a little bit about the motivation behind the paper?
Yeah, so this has been on our mind for a long time. When I started working on histiocytosis back in fellowship, we would see a lot of patients with ECD, Erdheim-Chester disease, or with Langerhans histiocytosis who would have diabetes insipidus. That was the old name. Now it is called AVP deficiency. Who would have this long-standing history of going to the bathroom a lot, drinking a lot of water, and they had this diagnosis of idiopathic diabetes insipidus, meaning that we didn't know what was causing it. And then years later, they developed other organ involvement and they were diagnosed as histiocytosis. So on in our studies, we found that average time from symptom onset to diagnosis in general, especially in Erdheim-Chester disease, was very long. Average was 4 years, but actually many patients it was over a decade. So we then thought about what are sort of the frontline specialties that see these patients, that may be opportunities to capture these diagnoses early, so that that light bulb goes in the mind to think about histiocytosis and the differential. So one of the things at the forefront is this pituitary gland involvement that can cause endocrine dysfunction, or the other word is endocrinopathy, which can just go beyond diabetes insipidus. But diabetes insipidus is one of the initial manifestations. And so that is why we said we decided to target the audience that is the endocrinologist for this particular article. And I was fortunate to be able to partner with Dr. Makras here, who has been doing extensive research in this field. And we were able to come up with a framework, a simplified framework for the endocrinologists the doctors who deal with other hormone disorders as well, who, when they see them in the clinic, they can think about what are the questions they need to ask, what are the tests they need to do to capture the diagnosis early. Because even in our center, after we have a special pituitary clinic, after we started spreading awareness about the pituitary involvement aspects, we have been able to capture some diagnosis early just by mere awareness of these diseases. And so we provide a framework of that will help the endocrinologists in the clinic. They don't have to know everything about the disease, but just simple things that they can do to help figure out whether this could be it or not. Because 10% of pituitary involvement of all cases in a couple of studies have shown to be due to histiocytosis when they looked at the biopsy samples. So I think this was a lot of hard work, and I think the community had asked a lot for something like this to spread awareness. So we are very excited to have to see this in print.
It is very exciting to your point. We absolutely interact with so many families who have questions about this, and there's also there's a Facebook community for people who have diabetes insipidus now, AVPD, and I know a lot of times the entry point is through the pituitary involvement, and then later discover the connection. So really excited to learn more about this. So before we talk about the workup to be done for patients and monitoring and what endocrinologists should be testing for, Dr. Makras, what was the most significant takeaway from you through this?
I think, as also Dr. Goyal pointed out very carefully and correctly, of course, is that the most important takeaway is the fact that endocrinologists might be the first doctors to see a patient with an histiocytosis, Langerhans cell histiocytosis or Erdheim-Chester disease. So I think that we try to raise awareness, as already said, and I believe that knowledge is power. So if we give these raise awareness and give the knowledge to endocrinologists, and I believe that because I'm working with colleagues who are endocrinologists, and everybody knows, have heard about histiocytosis. However, if we try to, uh, let's say, to construct an educative paper, so to give the pathway from to deal with a patient that we suspect that he or she is suffering from histiocytosis. So I think this is the most significant takeaway, and early diagnosis can be done from endocrinologists, and this will lead to an efficient management. So I believe that this is probably the most important thing of this paper. And I was also very excited to work with Dr. Goyal, with Gaurav.
Thank you so much. So, I know that the workup for people who have suspected or known histiocytosis is an important piece of this. Dr. Makras, we're going to hear from you about the monitoring and testing that endocrinologists should be doing. Dr. Goyle, what is the workup that should be done for people with suspected or known histiocytosis?
Yeah, so I think the most, if there is one thing that people should take a look at in the manuscript, if they, there's a lot of information in there, but the one thing that definitely should be looked at is the algorithm, a simplified algorithm that is provided that, hey, you have a patient in front of you who has pituitary hormone abnormalities, maybe diabetes insipidus or something else. What few things can be done to figure out whether the person has histiocytosis? Generally, when we suspect histiocytosis, for various reasons, we always ask for common things, the common organ involvements, which can present with some characteristic symptoms. They may not be specific to histiocytosis, but they can raise some flags. For example, in addition to the endocrine abnormalities, the going to the bathroom a lot, or drinking a lot of water during the day, do they have bone pains? Sometimes they may have scans for other reasons that may show some characteristic features, such as the hairy kidney, a coating around the kidney that has that looks like a wispy infiltration. That is classic for Erdheim-Chester disease. They could have knee bone involvement, which is seen in 90% of cases with Erdheim-Chester disease. So actually, the bone being an interesting and important location for these disorders, one of the things that we suggest, the first sort of step after asking these questions, since these questions may also be non-specific, is if other etiologies have been ruled out, other causes have been ruled out. That is when we use the word idiopathic, right? Because other cases can happen too. But if other things have been rolled out, it is, we think that it may be at least wise to get the first screening test as a bone scan, if not a PET scan. In our practice in hematology, even our endocrinologists are now getting comfortable with ordering a PET scan after they communicate with us. So it's okay to partner with a hematologist if you have a concern. uh, but at the very least, we suggest doing a full body technetium bone scan, which can show those classic knee bone involvement that is seen in Erdheim-Chester disease. In addition, a CT scan of the body can be done as well to look for other organ involvement. Now, this is just pertaining to histiocytosis. Once you see those spots, the key in histiocytosis diagnosis still relies on a biopsy. Now, pituitary is not necessarily the safest or the first thing you think of doing a biopsy of. So, the other important part of doing those scans is to find a spot that can be biopsied. So the next step then is to recommend, if you see a spot on the bones or on the CT scan somewhere else, because these can be multi-organ involvements, and the next step is to consider doing a biopsy and having it reviewed by a pathologist. With the most important thing there is to just give a hint, because that's the second layer, is the pathologist also needs to be aware that we are looking for, or we are thinking of histiocytosis, because that can, the pathologic manifestation of Erdheim-Chester disease specifically can be non-specific. It could just say inflammation. So we don't want to, we do all this workup, we don't want to miss the diagnosis even after that. So it's important to ask the pathologist specifically, hey, look for histiocytosis, or partner with a pathologist who sees a lot of these. And sometimes it may not be crystal clear, and that time it's important to reach out for to a center that sees a lot of these individuals. And the list of those such centers and knowledgeable doctors is already available on the histiocytosis association website. But the first thing is, have the light bulb of the histiocytic disorder. Think about those relevant questions. Look at if there is other scans that have been done that shown brain involvement, kidney involvement, bone involvement, and then think about doing a biopsy. If no scans have been done, think about doing a scan. That should be the first step to rule it out.
Thank you so much for so elegantly walking through that. I know that's very helpful. And, for providers that are watching, that gives a really clear roadmap. And then for families who maybe are trying to navigate this with their providers, that helps them be able to bring, very, very clear idea of what to do. And so I know that it doesn't stop there. There's also monitoring for endocrine involvement, and then things that endocrinologists should be testing for. Dr. Makras, would you like to address both of those? What is the monitoring for endocrine involvement, and what should endocrinologists be looking for and testing for?
Yes, of course. I think that before saying that, and before saying is the monitoring, maybe I should make a small introduction of the pituitary gland, as already Dr. Goyal pointed out. Let's imagine that, let's suppose that pituitary gland is the general of the endocrine glands, the main computer, whatever you can call it. So it controls the other endocrine organs. So it gives order to the thyroid gland, to the adrenals, to the testes in males or in the ovaries for the females. It controls the growth when we are young, or controls even through the growth hormone our metabolism. So if we have an infiltration of the pituitary gland, of the main computer, let's say, then we may have some other disorders from the other endocrine glands, however, without being affected. For example, if we have the part of the pituitary gland affected that controls the thyroid gland, then we may have hypothyroidism without a thyroid gland being affected, just because the thyroid gland doesn't receive any message to work. So this is a very different pattern from the primary, let's say, deficiency of the thyroid gland. I'm just giving you an example. So we endocrinologists should have that in mind, because the pattern of the endocrine tests are different, because it is a different pattern when you have, let's say, a thyroid gland affected by thyroiditis. It's a different pattern of hormonal evaluation if you have the pituitary gland affected, which is uh, uh, somewhere here between the eyes, inside the skull, and gives the, let's say, the message to the pituitary gland. So by having said that, I should let's say, proceed to the test that we are using. And of course, we have to see whether the thyroid gland is, for example, working well and having the right messages. The adrenal glands, which are it's very important glands. It's because very important for the life. So it is, let's say, we don't want to have an adrenal insufficiency, because this is dangerous for the life of every patient. So we have this test for the adrenals. We have the test for the ovaries of or the testes in males, and of course, we have the test for a growth hormone. And as also Dr. Goyal already said, we have to check whether the uh, arginine vasopressin deficiency exists or not, because this is also controlled by the pituitary gland. So if we have a deficiency, it is the posterior part of the pituitary gland, then we don't have this hormone that controls the urination. So we pass urine, patients pass urine a lot without being controlled. So these are usually the tests we are using to check the integrity of the pituitary gland. And of course, we have other, let's say, endocrine manifestations. Sometimes we have the bone metabolism affected. Patients may have also osteoporosis, and now I'm talking mainly for older patients, but also in the younger age, we can have a decreased bone mineral density. And we also have some let's say, evidence that also the glucose metabolism can be affected because of because of the histiocytosis. But this is I think that a lot of research has to be done in this field as well. So if we want to evaluate and monitor patients, we should have in mind all these things that I have addressed. And of course, if we have a known, let's say, a known endocrinological problem, we should monitor our patients. And we suggest, and also it's suggested from the recommendations, and Dr. Goyal was the first author in this excellent paper in Blood 2 years ago. And we should monitor these patients every 1 or 2 years. And of course, this approach is not, we don't know whether it is cost effective or not, because there is a variety of manifestations among patients. But I believe that if we, let's say, have in mind that our patients can have an endocrinological problem during the course of the disease, I believe that if we check them every 1 or 2 years, this is okay, and we can be sure that we will not miss a lot of patients having endocrinological problems.
Thank you so much for walking through all of that. That's very helpful, and it's evident that the endocrinologist plays a huge role in not only diagnosing histiocytosis when there is pituitary or endocrine involvement, but also will play a role in that person's journey for quite some time, if not sort of indefinitely, depending on how the patient's feeling. So thank you for drawing attention to this. And so I imagine that there are key takeaways for endocrinologists to be thinking about. Maybe Dr. Goyle, if you want to start, and then Dr. Makras, you can build on that. What are the key takeaways for endocrinologists?
Yeah, I love what Zoe said. You know, the pituitary as a master computer. I think this may be a very good important educational aspect of this talk as well, because I think it's a very complex organ. It's a tiny organ, but it controls a lot of things, a lot of function of the body. And something we have not talked about is how much effect the hormone deficiencies can have on someone's physical and mental health. And so one of the things that, as Zois was talking, I wrote down to mention is, if somebody has LCH or Erdheim Chester disease, definitely the endocrinologist, as the guidelines also suggest, and Zois said, that should be checking for these hormone abnormalities. The other thing to keep in mind, and the historical data have shown that, and Zois has done work on this, is that we may underestimating the endocrine dysfunction. We have not really took a series of individuals with LCH or ECD and tested all the hormones at baseline for a lot of them. For small studies, when they have done it, it's shown to be much more than what has been thought, to the degree of hormone abnormalities. And the other thing that traditional or conventional wisdom has taught us is that just because someone is on treatment for histiocytosis does not mean that the endocrinopathy or the endocrine dysfunction will reverse itself. So, this is very important, because I see individuals who have this pituitary hormone deficiency, they need to still be seeing an endocrinologist. In fact, there are some data, maybe old but still there, suggesting that there may be development of new hormone abnormalities as the disease course progresses. At least that was based on older treatments. We don't know if that is true for the newer targeted treatments. And that is why I think it's very important to catch this diagnosis early, because we can see whether we can intervene, because this is a huge quality of life issue. And so, if individuals with LCH or ECD have these symptoms, common symptoms from endocrine dysfunction beyond the going to bathroom and drinking water can be just fatigue, just not feeling like doing anything. Hormone dysfunction can lead to the thyroid dysfunction, can lead to, if it is low, the hormone can lead to weight gain. Not feeling like doing anything. So things like that. So if someone has those diseases and feels poorly, it is wise, or it is important actually, to advocate for yourself and ask your oncologist or hematologist, hey, have I had a hormone evaluation done, or can you refer me to an endocrinologist for doing a hormone evaluation, because I don't feel good, and I may have something else, even though my LCH or ECD may be in remission. We just don't know with new BRAF and MEK inhibitors whether the same thing holds true regarding development of new endocrinopathies or irreversibility of the endocrinopathies while they are on the Zelboraf, the Kotelic, and so forth. These are the trade names of emirafinib and cobimetinib. So that's still to be seen. A lot of work needs to be done. So that's why we are doing the long-term follow-up study to figure out whether individuals who are getting these newer treatments are doing better in terms of physical and mental health, and some of these hormone dysfunctions. Maybe we are able to reverse them. We don't know. So that those are sort of the two main things that I think the endocrinologist should keep in mind. But I will let Zois chime in if I missed anything.
I think Gaurav, you said everything, and I fully agree with yeah, your approach. And as also you said before, I am let's say I think that maybe we may have some good results from the new targeted treatment. But of course, it is better not to have the endocrinological deficit, endocrinological problem, so early diagnosis. Because if we have an early diagnosis and we start treatment as soon as we can, then maybe we will stop, let's say, the evolution of the disease. We can stop the infiltration there, and keep as many hormones we can in order to, I mean, intact hormones we can, and or hormonal pathways. And I also uh, think that, I mean, from my point of view, because I'm a endocrinologist, and maybe my point is biased. Sometimes I see patients relapsing just with a hormonal deficiency without any other involvement, organ involvement or infiltration. So it's just a hormone that is missing during the course of the disease without any other involvement. But as I said, maybe it is my it's a biased idea because I usually see patients from endocrinological point of view. However, that's why we should monitor and we should ask our patients about their symptoms, especially those vague symptoms, as Gaurav said, fatigue, or let's say some metabolic problems, or not feeling very well. If we check these patients, we might have some, let's say, mildly affected hormones. So, because if we see that, we should go and do some dynamic testing, and then that they will reveal the hormonal problem. So, we should keep that in mind. So, having that in mind and increasing the awareness, especially among endocrinologists and, of course, among patients and other doctors are dealing, of course, with these rare diseases, we can have more early diagnosis and early management.
That's so important. From the beginning, you mentioned that, it could sometimes take up 10 years or so for someone to actually get the diagnosis of a histiocytic disorder from the original endocrine condition. So, all the points that you've brought up are just incredibly illustrative of the important role that the endocrinologist can play in helping to look under every rock to see what might be going on for a person who has, not only this endocrine condition, but other symptoms that could potentially be histiocytosis. So this is just a really important manuscript, and certainly something that we're eager to share. And we'll have the links to the manuscript for everyone to look at, and you reference other publications as well, so we can include the link to that in addition. Is there anything else that either of you want to share with the histiocytosis community, either related to the manuscript or just in general?
I would say that it's 2025, and I would just like to say that the future of histiocytosis looks bright. We know way more than we did 10 years ago, and there are more and more people doing work on this from every front. So today's conversation was just about one of the aspects, which is very important. And but there are many, many, many other advances that are going to happen, and they've already happened in the last few years. So we are hopeful that with this study, the real thing we are hoping for is that we'll be able to capture more diagnosis earlier. Because it's easy to say it's a rare disease, but I think part of it is we are probably missing some of these cases and they're being delayed. So that's most important. And one thing I would like to say is, we gave a lot of information, and we talked about a lot of hormones, a lot of tests, but there are all tables in this manuscript that your doctors or the physicians can take a look at, the endocrinologists can take a look at. Even in the guidelines, we have provided concrete what are the tests that need to be done. So you don't have to, if you're a patient struggling with these diseases, you don't have to worry about memorizing this. You can provide them the link of the papers if it comes to that. And we in my clinic, at least, I have a screening list of labs that, as a hematologist, I've gotten so used to just ordering all of them. My endocrinologist friends, like Zoe's, have educated me enough to sort of do a whole list of tests. So that saves a lot of time and effort, and then everything is ready when and if they need to see an endocrinologist. So I'm able to do some screening tests early on. So that's all I would like to say. So please don't feel overwhelmed. This is just us providing information, and we are here if anybody has questions or anything. If they want to reach out, if they want to connect their physicians, our information is available. Thank you. I'm glad to be here on this channel, actually, I would say.
I think that we have covered, almost everything. So I don't have anything to add regarding the paper. I think Gaurav said uh, everything, and we have covered during this very friendly discussion. I just want to share my personal perspective because am also dealing with other patients having rare diseases, and I have to say that I'm very proud working with patients having histiocytosis, and I want to congratulate this global, let's say, patient society, because you are doing very hard work and you are dealing with the problem uh, by facing it. And I think what you are doing now, because as I said during this discussion, that knowledge is power. So we need to use knowledge wisely, and of course not be afraid for what we are reading, because what you read doesn't mean that you have it. So, but just to to be aware what other things can happen with the disease is power, I think. So it's better to know rather than not knowing anything, but be um, let's say make a step back and see what we learned and see whether this can be, let's say, incorporated in our case. Thank you very much for this invitation. It was a lovely conversation. I really enjoyed it.
Thank you both so much for taking the time to walk through the manuscript and to bring in your expertise and your perspective. It truly means the world to us to be able to hear from you the background and motivation behind the work that you're doing and the takeaways so that we can share this with providers around the world and families around the world. We know that this is going to be very beneficial. So thank you for everything that you're doing and for the heart and passion that you pour into our rare community. We really appreciate you so much.